For the next few minutes, we're going to be talking about letter-perfect CPR or high-performance CPR. As shown in this slide, CPR is the foundation, the cornerstone of virtually every treatment in resuscitation. Take away CPR and virtually every other treatment loses its effectiveness. Why is it that CPR can enhance even something like defibrillation? Well, this slide illustrates how that can occur. This slide is describing 10 pigs who were put in cardiac arrest and kept in unsupported VF for a variable period of time, anywhere from 1 to 40 minutes. And during the time of VF, their hearts were sampled and the muscle samples were assayed for a compound called ATP. ATP stands for adenosine triphosphate. It is the fuel, the high energy compound that drives every energy process in the body, including the heart. Notice that as time goes on, ATP concentrations in the heart decline. Notice also that if you had a VF waveform occurring at the same time, what happens to that waveform with unsupported VF over time? It is coarse, and then it declines in its coarseness, finally becomes very fine, and ultimately looks like asystole. Now, you and I know what happens when you have unsupported VF, no CPR, and you shock late in the occurrence of VF. The rhythm you typically get is asystole or pulseless electrical activity. Why might that be the case? Well, in the late phases of VF, you may not have enough ATP left in the heart such that even if shock terminates the rhythm, you end up with either asystole, not enough ATP to even generate a QRS complex, or you end up with PEA, meaning a QRS complex, but no mechanical support to drive the heart as a result. So what are the essential components of CPR? Well, we can divide it into two phases, compression and decompression. And the point to remember is when we press on the chest, it's not just the heart we're trying to squeeze blood out of. It's the entire chest that becomes the pumping chamber by which CPR is effective. Compression, when we press on the chest, increases intrathoracic pressure. That ejects blood not only from the heart, but from the lungs and vessels and every component inside the chest, which means good compression empties the chest, increases forward output, and provides a blood pressure. In the decompression phase is where we allow the chest, the pump, to recoil. That recoil decreases intrathoracic pressure. In fact, it creates a vacuum inside the chest, and that vacuum is what refills the heart and lungs, which means the better the recoil, the stronger the vacuum, the better the refilling, and a heart that's more refilled will be ready for the next compression to provide even a better forward output. Let's look at that in greater detail by imagining the heart and putting catheters inside the heart amidst the compression and decompression phase of CPR. Let's first look at the left ventricular chamber. Let's put a catheter in that chamber and see what happens to pressure in the compression and decompression phase of CPR. And you can see the rise in pressure with compression and the fall in pressure down to 0 or so with decompression. Let's now put a catheter in the aorta, marked in red. And notice it behaves almost the same way. It increases in the compression phase of CPR, identical with left ventricular pressure, and it falls in the decompression phase. But notice that aortic pressure, unlike ventricular pressure, does not fall to 0. Why is that the case? The reason is because a critical event occurs right where you see the red arrow, and that is closure of the aortic valve. When the aortic valve closes, the diastolic pressure in the decompression phase of CPR is maintained above 0, so the aortic waveform looks different in diastole than the ventricular waveform. Now let's put a catheter in the right atrium. Now you and I are used to right atrial pressure being much lower than left ventricular pressure, but notice in CPR, the right atrial pressure and left ventricular pressure are virtually identical. Why is that the case? Because compression is what's creating that pressure, and it's creating it everywhere inside the heart and inside the chest, no matter what the chamber is. Now, let's also put a catheter outside the chest, in the internal jugular vein. If we do that, the pressure waveform, which you see in dots in gray and below, look different. And they look different than the pressures in the heart because of valves that are present in the veins that prevent pressure in the chest from entering the veins themselves. So the veins outside the chest are protected from what's happening when we do CPR. That is a critical observation to make because what drives organ perfusion in the brain and the kidneys, the rest of the body, is the difference between aortic pressure, pushing blood into that organ, and the venous pressure, which is the back pressure against the blood trying to flow in. If it weren't for those valves, meaning if the venous pressure outside the chest were identical to what's happening in the chest in CPR, this would not be an effective intervention. So organ perfusion is critical between the aortic pressure and the venous pressure. Now, every organ in the body gets blood supply during the compression phase of CPR except one critical organ. And that critical organ happens to be the heart. The reason for that is what perfuses the heart are the coronary arteries. The coronary arteries take off from the aorta, and they ultimately dump blood back into the right atrium. Well, look at the compression phase of CPR. What's the difference between aortic pressure and right atrial pressure? 0. So there can be no coronary blood flow during that phase of CPR. On the other hand, in the decompression phase of CPR is where aortic pressure falls but not to 0, right atrial pressure falls just about to 0, and that's where you have the heart as well as other organs perfusing. Why is that important? It's important because when we do CPR, we need to think about each phase of compression and decompression as having at least equal importance. And I try to think of it when I do CPR as this: brain, heart, brain, heart, brain, heart, recognizing that both phases are critical in perfusing those organs. Now, how do we optimize or create high-performance CPR? Well, the way we optimize CPR is to set goals. And the goals that we set are the metrics by which we judge our performance and try to improve outcome. The 4 metrics of high-performance CPR are pretty simple. Optimize your chest compression rate, 100 to 120 compressions per minute. Maximize your depth, at least 2 inches. Promote full chest recoil. Don't lean on the chest in the recoil phase. And minimize interruptions, meaning keep your chest compression fraction as high as you can possibly get it. So let's talk first about optimizing chest compression rate and chest compression depth. Where did these numbers come from? 100 to 120 compressions per minute and at least 2 inches of chest depth. Originally, they came from animal studies and consensus because they seemed to be a reasonable guess to match human physiology. But in the last few years, we now have clinical data from trials and studies that have evaluated CPR performance and been able to correlate some of these numbers with outcomes. For example, if you look at chest compression rate and the probability of surviving out-of-hospital cardiac arrest in about 3,000 patients with cardiac arrest, notice the yellow curve improves at about 100 to 120 compressions per minute, right where we're recommending chest compression rate. Notice also that at slower rates, survival tends to decline. And here's another important point to appreciate. At faster rates, survival also declines. So there is a sweet spot, not too slow, not too fast, by which chest compression truly makes a difference. What about chest compression depth? Well, here's a study of 1,000 patients in out-of-hospital cardiac arrest where the depth of compression was measured and correlated with survival. And what you can see is that about 2 inches is where maximum depth seems to achieve the best survival from cardiac arrest, suggesting these are reasonable parameters and they improve outcome if we adhere to them. So we've talked about chest compression depth and chest compression rate. Let's talk a little bit about full chest recoil, or not leaning in the process of decompressing the heart. And let me just give you a reminder. What happens in the decompression phase of CPR? That's where intrathoracic pressure diminishes because it's recoil, and that refilling process occurs in that phase. The better the recoil, the stronger that vacuum, the better the refilling, and the better the following output from the compression. Now, let's look at that in detail. Here's CPR that's ongoing. And if we allow for full recoil of the chest, what's happening inside the chest during that process of CPR? And here's what it looks like. The chest compressions are the small blips in blue. The breaths you can see that are the larger blips. And all those, when you're compressing on the chest, increase the pressure inside the chest. That's the whole process of compression. But notice also that those compressions fall below the zero baseline, meaning during the recoil phase of CPR, you're actually creating a negative pressure when you lift your hand completely off the chest. Allowing that complete recoil is what allows refilling of the heart. What if you don't do that? What if you continue to maintain some pressure on the chest and don't lift it off? What happens to the appearance of that waveform? Well, here's what it looks like. You still have the compressions, you still have the breath, but notice the pressure never falls below zero. You're always maintaining a positive pressure in the chest. That vacuum can't occur in order to refill the heart. Now that has a couple of consequences. One is if you don't fill the heart very well, you don't have good filling for the next compression. But the other effect it can have is it can actually hurt perfusion during the recoil phase of CPR. And let's do that by chopping off the compression phase and looking specifically at the pressures in the aorta, the left ventricle, the right atrium, and the extrathoracic veins during the decompression phase. And if you look at the diagram, if you fail to lift your hands off the chest, you in effect are maintaining a pressure on the chest. That pressure is seen by the left ventricle and the right atrium, and the diastolic pressure in the chest increases. If you increase that pressure inside the right atrium and the left ventricle, particularly the right atrium, look what happens to coronary perfusion. It diminishes because you now have a narrower pressure range between the aorta and the right atrium. Now, what effect does that have? Well, we've already talked about it. You diminish coronary perfusion, the heart's losing some of its blood supply. But it can also have a second consequence. Remember, the brain also ultimately dumps blood into the right atrium. And if right atrial pressure is higher because we're not lifting our hands off the chest, the brain is seeing higher right atrial pressure. That increases intracranial pressure. Increased intracranial pressure decreases brain perfusion. So in effect, we hurt both the heart and we hurt the brain when decompression phase of CPR is not adequately performed. Let's talk about the fourth metric of high-performance CPR, and that is to minimize interruptions and maintain a high chest compression fraction. This slide describes a CPR sequence showing the waveform in the aorta and the right atrium during CPR, and it's compressed just to slide it in over a particular time period. You can see the red arrows depict where CPR systole is occurring. That's where aortic pressure and right atrial pressure are at the same level. And the diastole phase, or decompression phase of CPR, where right atrial pressure falls to about zero or less, and the aortic pressure falls but not quite below that. Notice also at the end of the slide, when we pause CPR within 3 seconds, all pressures cease. Aortic pressure falls to zero, right atrial pressure falls to zero, and there's no flow anywhere, brain, heart, or anywhere else. Now, here's the common mistake that a lot of us make, saying, okay, gee, no big deal, 3 seconds of pause, I'll get my hands right back on the chest, we'll pick up right where we left off. Well, not exactly. When you put your hands back on the chest, you do not begin where you left off, you start right back at the beginning. And notice that it takes another 30 compressions, or about 16 seconds, to rebuild the same kind of blood flow you had before you paused. Simple equation. Even a 3-second pause ends up costing you about 20 seconds of adequate blood flow, meaning every pause hurts more than the pause itself creates in terms of blood pressure loss. Now, what consequence does that have on outcome in cardiac arrest? Well, if you think of CPR fraction as the percent of time a pulseless patient is getting chest compressions, you'd really like that to be as close to 100% as possible, meaning you'd like to fill the clock completely with CPR. But every pause in CPR detracts from that time clock. It takes away from CPR percentage and CPR fraction. And what impact can that have on outcome? Well, let's say you're only doing a chest compression, CPR compression fraction of about 20%, meaning lots of interruptions in CPR that are detracting from CPR. Your likelihood of surviving from VF cardiac arrest to discharge is only about 12%. But if you can diminish those pauses, get your CPR fraction up to 40, 60, 80, maybe even close to 100%, notice that you can almost triple the likelihood of surviving a cardiac arrest. Or put another way, for every 10% you can make CPR fraction better by having fewer pauses, you can buy about an 11% improvement in survival from out-of-hospital cardiac arrest. So let's review. What are the 4 metrics of high-performance CPR? Number 1, optimize chest compression rate, 100 to 120 compressions per minute. Number 2, maximize depth, minimum of 2 inches. Number 3, promote full chest recoil, let that chest bounce back. And number 4, minimize interruptions, keep that chest compression fraction as high as you possibly can. In summary, it's not complicated. Here's all you got to remember. Press hard, press fast, but remember not too fast. Don't lean, and don't pause. If you can perform this level of CPR, your hands will improve the outcome of the next patient you treat in cardiac arrest.